Good morning, respected Emeritus Chairperson, sir, VC, sir, Pro VC, sir, Principal, sir, senior faculty members, my dear colleagues. Good morning. So, today we will be presenting an interesting case from Department of Pediatrics, and on behalf of Department of Pediatrics, I welcome you all. So, before moving on to the case, I would like to share some brief data and stats of our pediatric ICU. So, with all respect and all support from MGUMST management, we have been provided with good equipments and all kind of facilities which are equivalent to the Western world. And in 2022, the number of admissions were 651. 2023, it increased to 789. This was a significant jump. And till June 2024, the number of admissions are 383. System-wise distribution of the cases, most number of cases were of renal origin, that is 32%, followed by CNS, GIT, and trauma. I would like to highlight here that the number of trauma cases are highest in Rajasthan. We are catering all kind of polytrauma, fall from height, roadside accident, insect bite and animal bite, which is quite a good number as compared to the other PICUs of northern India. Now, this is the most important slide which depicts the performance of pediatric ICU or any other ICU, the ventilation and mortality ratio, the number of patients ventilated and outcome of those patients. So, as we can clearly see, in the month of August, September and October last year, the highest number of ventilated patients were present. They were around 45 to 50, and the mortality was only 3 to 4% in those patients. 3 to 5% mortality is as per the Western data, and we are able to match that particular number in our pediatric ICU setting. The minimum number of mortality which was documented was in the month of January and February this year. This clearly depicts the performance of any ICU, and this is the 3 to 5% of mortality in our pediatric ICU setup. So now moving on to our case, I would like to invite Dr. Nishtha Gupta. She will be presenting the case, and she is JR2 in Department of Pediatrics.
Thank you, sir. Good morning, respected Emeritus Chairperson, sir, respected faculty members, seniors, and my dear colleagues. So the case for today's CCR is a 5-year-old child with loose stools and depressed sensorium. So we received a patient in the emergency in a life-threatening situation. Initial management and assessment of the patient was done in emergency itself, and then the history taking and examination was performed. Upon history taking, there was complaint of fever since 7 days, loose stools since 3 days, generalized swelling since 2 days, and complaint of depressed sensorium since 1 day. So as the patient landed in emergency in unresponsive state and in impending respiratory failure, he had vitals of maintaining oxygen saturation of 65% on room air. He was tachycardic, tachypneic. Patient was febrile with a temperature of 101 degrees Fahrenheit by axilla, and blood pressure was 140 by 100 mmHg. According to pediatric advanced life support, on initial impression, patient was pale in color. There was increased work of breathing, and the child was unresponsive with a GCS of E2, V1 and M3. So the patient was intubated in emergency after taking parental consent, and initial stabilization was done. He was taken on mechanical ventilation support on synchronized intermittent mandatory ventilation volume control mode. And the first dose of broad spectrum antibiotic, which was piperacillin and tazobactam, was given after drawing all the basic blood samples, and urinary catheterization of the patient was done to monitor urine output. On primary assessment, first starting from airway, patient was intubated and it was uneventful. He maintained a saturation of 97% on mechanical ventilation. He was tachycardic. Blood pressure was 140 by 100 mmHg, which falls in the category of grade 2 hypertension. Color of the child was pale. The pupils were bilaterally equal and reactive to light. And on exposure, the temperature of the patient was 101 degrees Fahrenheit by axilla, and generalized edema was present. So now the complaints which were mentioned earlier will be discussed in detail. See, he had complained of fever since 7 days, which was sudden in onset, intermittent in course. There were 1 to 2 spikes of fever per day, each of which lasted for around 2 to 3 days according to parents. It was not associated with chills and rigor, and the fever was relieved upon taking medications. Complaint of vomiting was present since 4 days. There were 2 to 3 episodes of vomiting per day. It contained partially digested food particles. It was non-projectile and there was no blood in vomitus. Loose stools were present since 4 days. There were 5 to 6 episodes of watery, non-foul smelling stools per day, out of which 1 to 2 episodes were mixed with fresh blood and mucus. And this complaint was not associated with pain in abdomen. Also, parents mentioned that they noticed generalized swelling since 2 days, which first started on periorbital region, then gradually progressed to both lower limbs. He also had complaint of depressed sensorium since 1 day, which started with increased sleepiness, and it worsened rapidly, and patient was in unconscious state since 3 hours. There was no history of any outside food ingestion, trauma, any insect or animal bite, any medication or toxin ingestion. There was no history of rashes, blood in urine, yellowish discoloration of body and eyes. There was no history of decreased urine output, abnormal body movement or localized weakness or headache. There was no significant past history. Patient was immunized as per National Immunization Program for his age, and the milestones were appropriate for age according to parents. There is no significant family history. The child has 1 younger male sibling who is healthy. Dietary history was calculated as per dietary recall, and it was found out that there was around 9% deficit of calorie and there was around 20% protein deficit. As the child was already on mechanical ventilation, he was tachycardic. The peripheral pulses were normal in volume. It was regular. There was no radial or radiofemoral delay. The respiratory rate of the ventilator was kept at 35 per minute. The blood pressure was 140 by 100 mmHg. It was measured in right upper limb in supine position by auscultatory method. So according to American Association of Pediatrics as well as Indian Association of Pediatrics, this reading of blood pressure falls in the category of hypertension stage 2. Also, blood pressure was measured in all 4 limbs and there was no significant difference. Temperature was 101 degrees Fahrenheit, which was measured by axilla, and he maintained a saturation of 98% on mechanical ventilation. The child had a weight of 15 kgs, which lies between 10 and 25th centile for age, which can be seen here by WHO and IAP combined growth chart. The length was 105 centimeters, which again lies between 10th and 25th centile for age. Mid upper arm circumference of the patient was normal, which was 13.5 centimeters. The child had pallor and generalized edema. The edema was pitting in nature and it was present in periorbital region and both lower limbs. Icterus, clubbing, cyanosis and lymphadenopathy was absent. So the central nervous system examination was done, but the patient was already intubated and was on sedation, so only pupils were examined, which were bilaterally equal and reactive to light, and fundus examination was normal. Rest of the CNS examination could not be done as the patient was sedated. On inspection, abdomen was normal. There was hepatomegaly, which was 3 cm below right subcostal margin in mid-clavicular line, and the margins of the liver were well defined. It was smooth in surface and soft in consistency. Liver span was around 10 cm, whereas normal for this age is 8 cm. There were normal bowel sounds on auscultation and genitalia was also normal. Respiratory system examination, there were bilateral basal crepitations on auscultation and air entry was reduced in right infraclavicular area. Rest of the cardiovascular and respiratory system examination was normal. So after this initial assessment and examination, we can summarize that there was a 5-year-old male child who landed in a life-threatening situation in emergency. He had complaints of fever since 7 days, vomiting since 4 days, blood mixed loose stools since 3 days, generalized swelling since 2 days, depressed sensorium was present since 1 day, and he was unconscious since 3 hours. On examination, there was pallor, grade 2 hypertension, hepatomegaly, bilateral basal crepitations and generalized pitting edema. So now I would like to ask from the audience, like, looking at this summary, what can be the clinical possibilities?
Dysentery or hypertensive encephalopathy, or maybe the child landed in sepsis in the emergency. So can you also think of something which incorporates the generalized edema which the patient has in this scenario? Anybody? Any
renal failure, liver failure, or renal failure?
Correct. That's also what we should think of. Yeah. And is hypertension a usual feature there? Will that be a red flag for you? Why does that little kid have high blood pressure?
In renal failure, sir, it can be a usual feature.
So any other possibilities? Any medicine resident, pediatric resident? Faculty not allowed. Only resident. Anybody? Okay, carry on please.
Thank you, sir. So clinical possibilities can be categorized into three. So as we saw that the patient had fever, loose stools mixed with blood, and he was in respiratory distress. So our first possibility can be any infective causes. It can be septicemia due to various causes like bacteria or viruses, can be acute dysentery, scrub typhus, leptospira, malaria, dengue, and enteric fever. So other possibility can be renal cause because the patient was in hypertension and there was generalized edema. So any acute glomerulopathy can be associated with these infective causes. And as the patient was unconscious since last 3 hours and he had complained of depressed sensorium since 1 day, CNS involvement can be there. So it can be acute encephalopathy syndrome as a sequel of any of the infective causes listed here. So to rule out these differentials and come to a probable diagnosis, various investigations were requested, in which hemoglobin was low, there was thrombocytopenia, the reticulocyte count and LDH levels were raised, and also the blood urea and serum creatinine levels were raised. Urine examination was done, which revealed that there was 2+ proteinuria and there were 10 to 12 RBCs per high power field in the urine sample. Also urine protein creatinine ratio was done, which was 1.67, which was not nephrotic range proteinuria. Blood and urine culture samples were sent for septicemia, so that was sterile. Tests for all the infective causes which I enumerated earlier were done, which include scrub typhus, malaria, leptospira, dengue, and enteric, and for that the tests were negative. Also after intubation, post-intubation X-ray was done. It is an AP view X-ray which showed bilateral homogeneous opacities, especially in the upper and middle zones, and which can be due to pulmonary edema or fluid overload, and ET can be seen at T2 level and NG tube is there in situ. So as we saw that the patient had anemia, thrombocytopenia, LDH count, LDH levels and retic count were raised, so a hematological etiology was suspected. So to discuss that in detail, I would like to request Dr. Shweta Bansal ma'am to take the case forward.
Good morning to all. I will cover the hematological aspect of this case. So whenever we, on the basis of clinical findings, we and the complete blood count, we examine the peripheral smear. So on peripheral smear, we read in 3 aspects. What are the findings of red blood cell count, WBC counts, and the platelet morphology. So one by one we discuss what are the findings we have observed in the peripheral smear. So this is the first slide. You are observed. These are the RBCs. What are these morphology? This shows normocytic, normochromic. Why this is normocytic, normochromic? Because no central pallor is seen, and you are able to see these are the fragmented RBCs. What are the fragmented RBCs? Anyone explain what are the fragmented RBCs? Why it developed? Okay. So whenever the RBCs faces some problem in the blood vessels or because of thrombus formation, it faces some mechanical stress. So because of this, it gets broken into pieces. And what are the fragmented cells? It can be of any shape like triangle cells, helmet cells, round or spiculated cells, or moon shaped. So you are able to appreciate these are the fragmented cells. How can we calculate this? We taking the 10 high power field and on the basis of RBC percentage, we are able to appreciate what are the percentage of cystocytes. So when it is come more than 1%, it is significant. So you are able to appreciate there are so many cystocytes seen in the peripheral smear. So because of the marrow field, there is some anemia developed. It compensatory increase the erythroids production. Because of this, it releases some young or immature RBCs in the peripheral blood. So you are able to appreciate some violet color stained RBCs. What are these cells? Anyone can say? No. We say in the peripheral smear, these are the polychromatophils. On the by conforming the polychromatophils, we stain another stain, that is this is a methine violet stain, which is able to appreciate the reticulocyte count. So on the basis of this, you are able to appreciate some blue precipitate cells in the RBCs. So these are the reticulocyte count or the polychromatophils. So polychromatophils are the young RBCs which contain some ribosomal RNA content. Okay, on methyl violet stain or brilliant crystal blue, it takes blue precipitate. How we calculate this? Again, we taking a oil immersion field, 10 fields, calculate the percentage of reticulocyte count upon the 100 RBCs. So if it is come normal range is 0.5 to 2.5%. If it is come more than 2.5%, it is significant and it indicates some hemolysis occur in the peripherals in the blood. Again, one important thing which you are able to appreciate in the peripheral smear, these are the platelets. So it's how we calculate platelets in the peripheral smear. Again, we take a 100 oil immersion field, calculate the 10 fields, what are the percentage of platelets are come, we taken as a platelet morphology. So it is decreased on the peripheral smear. So on the basis of these findings, RBCs are normocytic normochromic, along with the fragmented RBCs are seen, polychromatophils are increased, and thrombocytopenia means platelets are decreased. So final impression was made is finding are suggestive of hemolytic anemia along with thrombocytopenia. So possibilities considered are thrombotic thrombocytopenic purpura or hemolytic uremic syndrome. So I would like to invite Dr. Nishtha for further.
Thank you, ma'am. So what do we know about this case till now? There was a 5-year-old male child who landed in emergency in a life-threatening situation and was intubated there. He had complaints of fever, blood mixed loose stools. He was unconscious since 3 hours. There was pallor, generalized swelling and hypertension. And on investigations, there was anemia, thrombocytopenia. LDH levels were raised to more than 7 times of the normal value. PBF was suggestive of 15 to 18% cystocytes, and the patient was in acute kidney injury. So I would now again ask from the audience that now what can be the probable diagnosis? Okay. So as the blood culture and urine culture was sterile, septicemia is now unlikely. Also, all the tests for other infective causes were done, which were negative, so those causes are also unlikely, so they are ruled out. Now we are left with acute dysentery, which there can be involvement of renal system in the form of any acute glomerulopathy and also acute encephalopathy syndrome along with that. So looking at this scenario and the investigations which were mentioned earlier, we can come to 2 final possibilities. One is hemolytic uremic syndrome and the other is thrombotic thrombocytopenic purpura. Both of these are thrombotic microangiopathies as said. Now I would like to enumerate some differentiating features between these two first. So HOS is a renal thrombotic microangiopathy, whereas TTP is a cerebral thrombotic microangiopathy. HOS is more common in children as compared to TTP. There are more prominent renal symptoms are present in HOS, whereas CNS symptoms are more prominent in TTP. AKI is mild in TTP whereas it is severe in HOS. Hypertension is more common in HOS. Also there is ADAMTS13 mutation in TTP and HOS has multifactorial etiology. So our patient had features mimicking both of these conditions as highlighted here. So to come to a more probable diagnosis, some specific investigations were done. So one of the most common cause of hemolytic uremic syndrome is dysentery associated HUS. For this, stool culture and stool multiplex PCR was done. This stool multiplex PCR detects Shiga toxin associated E. coli, which is one of the most common cause of dysentery associated HUS, along with other organisms. So this was reported negative. So this type of HUS was ruled out. Another type of HUS is atypical HUS. In this, one is complement mediated, for which C3, C4 levels were done, which were again normal. In India, more than 50% cases of HUS are due to anti-factor H antibody mediated. For that also some special test was done, which I will be discussing in next slide, which was also negative. So we were left with only genetically mediated atypical HUS. Now a second possibility was TTP. So this can be due to ADAMTS13 deficiency, but also according to KDIGO, routine testing for this deficiency is not recommended. There can be ADAMTS13 mutation also, which will be detected again by genetic analysis. So final mutation analysis will help us to differentiate between these two possibilities. One is atypical HUS and the other is thrombotic thrombocytopenic purpura. So I mentioned a test anti-factor H antibody here. I would like to enumerate some points about it. What is complement factor H? It is a regulator of the alternate complement pathway. And the anti-factor H is an autoantibody that interferes with the ability of factor H to bind to C3 convertase, which in turn results in unrestricted amplification of C3b in the complement cascade and further membrane attack complex, which is responsible for the cascade of events and the etiology of our conditions. Although this test is not commercially available, it is done as a part of a research program in All India Institute of Medical Sciences, New Delhi. So we are thankful to AIIMS New Delhi to give us opportunity to perform this test. While this workup was done, simultaneously intensive care management in pediatric ICU of the patient was done. To discuss that in detail, I would like to request Dr. Satvir sir to take the case forward.
Thank you, Dr. Nishtha. Good morning, everyone. So I will be discussing the key aspect of the management carried out in the patient during the first 24 hours of admission to the pediatric intensive care unit. So upon arrival in the emergency, patient was intubated immediately and was transferred to the PICU, where he was placed on ventilator using the synchronized intermittent mandatory ventilation volume control mode with age appropriate settings. In addition to the ventilation, neuroprotective measures were implemented. These include targeting a PCO2 of 35 to 40 millimeter of mercury, maintaining head in elevated and midline position, and maintaining normothermia. And to ensure smooth ventilation and enhanced neuroprotection, analgesia, sedation and neuromuscular blockade were also started. So we are immensely grateful to our MGUMST management for providing us with a 24/7 ultrasound machine in our ICU. This resource has revolutionized our ability to deliver prompt and precise medical care, significantly enhancing patient outcomes. So during our routine point of care ultrasound, to assess the patient's fluid status, we examined inferior vena cava, which appeared distended with no respiratory variability. The distensibility index calculated was less than 18%, indicating fluid overload. To further confirm this, we conducted a chest ultrasound and observed more than 3 B lines in single window. These vertical lines, as demonstrated here in white arrows, if they are more than 3 in number, they are suggestive of the pulmonary edema. Following this assessment, we performed a functional echocardiography, which revealed no anatomical cardiac abnormality, and ejection fraction was measured at 55%, which was within the normal limit for this age group. Additionally, we calculated optic nerve sheath diameter, which is directly correlated with the brain edema. The measurement yielded 4 millimeter, indicating no significant brain edema was present. So to summarize the focus findings, the patient was having fluid overload with pulmonary edema, but there was no cardiac abnormality and there was no brain edema. And to address this pulmonary overload and pulmonary edema and fluid overload, we gave up furosemide challenge dose, but however, the response was inadequate. So the first issue we encountered was the deranged renal parameters. The initial renal function test shows elevated creatinine and urea level with slightly low urine output, normal being more than 1 ml per kg per hour in children. So there was necessitating modification of the antibiotic dose as per the estimated glomerular filtration rate. So after 12 hours of initial reports, repeat renal function test was done that indicated further worsening of the renal parameters. And as per the KIDIGO definition, the patient fell into acute kidney injury stage 1 as there was increase in the absolute creatinine value of more than 0.3 milligram per deciliter. So our patient was having fluid overload which was not responsive to furosemide and was having high urea content. So consequently, we planned for renal replacement therapy. Given the patient's hemodynamic instability and to prevent dialysis disequilibrium syndrome, we decided to proceed with slow, low efficiency daily dialysis. And to monitor and manage patient effectively, we placed a hemodialysis line, a central line and an arterial line in first 24 hours. As our patient was encephalopathic, so as soon as our dialysis was planned, we performed a contrast enhanced CT brain and found areas of hypodensities in the parieto-occipital lobe, which was suggestive of posterior reversible encephalopathy syndrome, most likely because of hypertension. So the next issue which we faced was hypertensive emergency. It is defined as acute severe hypertension with end organ damage. It is crucial to remember that in managing a hypertensive emergency, blood pressure should be gradually decreased to prevent hypoperfusion of the vital organs. So the goal is to target and reduce either systolic or mean arterial pressure to below 90th centile for the age, sex and height of the patient. So to better understand this, we have plotted a graph between time and blood pressure. The red line here represents the target blood pressure and the blue line represents the patient's actual blood pressure. So to reduce the pressure, as per the norms, we initiated infusion of sodium nitroprusside. It was titrated in every 30 minutes and reaching up to the maximum permissible limit in 4 hours. But however, this does not sufficiently reduce our blood pressure. So consequently, we added an infusion of labetalol and titrated carefully. Through gradual titration, we successfully achieved target blood pressures within 24 hours. So following stabilization, the intravenous antihypertensive medications were gradually tapered and the patient was transitioned to oral antihypertensive therapy over next few days. So this was the supportive management done in PICU but for the definitive management of the spectrum of hemolytic uremic syndrome and thrombotic thrombocytopenic purpura, therapeutic plasma exchange was done. And to explain it in detail, I would like to call Dr. Sunita from the Department of Pediatrics to explain it in details.
What are the indications of therapeutic plasma exchange? Here are some of the indications enlisted. So this hierarchy is based on the frequency that we have encountered in our ICU. The first one is hemolytic uremic syndrome, followed by acute liver failure, then acute inflammatory demyelinating polyradiculoneuropathy, poisoning, thrombotic thrombocytopenic purpura, and autoimmune hemolytic anemia. So what is the prerequisite for starting therapeutic plasma exchange? Before we initiate plasma exchange, we need to estimate the plasma volume, and that is done by this formula that is given here. So our child had a weight of 15 kg and an initial hematocrit of 24%. So his estimated plasma volume was 798 ml. Once we have estimated the plasma volume, we initiate the sessions of therapeutic plasma exchange. Initially we do it daily till the child goes into hematological remission, and then we taper and stop it over 4 weeks. Now what do we mean by hematological remission here? So patient is said to be in hematological remission when he has a platelet count of more than 1 lakh, schistocytes less than 2% on PVF, and LDH less than the upper limit of normal on 2 consecutive days. A replacement fluid that is used can be FFP or albumin. In our patient we used FFP. The procedure can be done with or without anticoagulation. We do it without any anticoagulation. So, as you can see here, our patient on admission had a platelet of 78,000, LDH of 1766, and schistocytes which were in the range of 15 to 18%. So, after 10 days of daily therapeutic plasma exchange, his platelet count rose to 1.8 lakhs, LDH was reduced to 230 units, and schistocytes were absent on his PVF. What are the principles or modalities of therapeutic plasma exchange? There are two principles by which therapeutic plasma exchange can be done. The first one is the membrane therapeutic plasma exchange, which is usually done using a hemodialysis machine, and this is the plasma filter that is used. This is P1 dry, which we use in children up to 10 kg, and about 10 kg we use P2 dry. So through this filter, plasma is convectively transported. The other modality is the centrifugation technique, which is usually used by the blood bank team, which instead of convective mode uses the centrifugal force for separating the blood components. But centrifugation TPE uses citrate as the anticoagulant, and citrate anticoagulant protocols are not validated in pediatric age group. So in our setting, we use membrane TPE. Now, while plasma exchange was going on, child had subsequent other developments during his stay in PICU. I now invite Dr. Ramesh to talk about further stay.
It is understood that plasma exchange can alter the biochemical parameters, but what is the mechanism? How does it alter the cell count? Because you said cell counts also improve. So what is the mechanism? How does plasma exchange help in improving the cell counts?
So it removes the circulating antibodies, abnormal proteins, toxins, cytokines which are present.
Direct effect on the cells.
Thank you, Dr. Sunita. Good morning, senior faculty members and dear colleagues. As Dr. Satvir has already discussed about initial 24 hours pediatric ICU management, I will be discussing further course in pediatric ICU along with the complication which we manage. So this is the timeline of critical issues which we encountered with. First one was the hypertensive emergency at the time of admission. On day 5th, we struggled with sedation withdrawal. Child also developed hospital-acquired infection on the 10th of admission. We also struggled to manage extubation failure and lung collapse on day 12th and day 17th respectively. And lastly, ICU-acquired weakness was noticed on 2nd and 3rd week of admission. So I will be discussing each and every issue one by one. As we have mentioned earlier, the child was presented in stage 2 hypertension along with CNS manifestations. So we started with sodium nitroprusside infusion. Gradually we increased the dose, and we also had to add injection labetalol infusion as well. Within next 24 hours, we could able to achieve BP targets. Gradually we continued the same infusion rate for next 24 to 48 hours, and then we started weaning antihypertensive infusions. On day 4th of admission, we stopped antihypertensive infusion and child was shifted into oral labetalol. As the BP was ranging within normal limits, so we stopped oral antihypertensive on day 6th of admission. For smooth mechanical ventilation, we started with sedation, injection midazolam infusion and injection fentanyl infusion. On day 4th onward, we started reducing the sedation by 20% every 24th hourly as per the standard sedation protocol. Within next 24 hours, after further reduction of sedation, we found that child is having recurrence of loose motion, tremors, and there was an increased muscle tone. So, with the possibility of sedation withdrawal symptom, we did withdrawal assessment tool version 1, which was clearly indicating that child was having sedation withdrawal symptoms as the score was showing more than 3 value. So, we had to stop further weaning of sedation. In next 24 hours, again this WAT score was done. Still the value was persisting more than 3. So, we had to increase the sedation to previous dose, and injection clonidine was also added in view of opioid and benzodiazepines withdrawal symptoms. Post these interventions, withdrawal symptoms were subsided, allowing for a 10% daily tapering of sedation from date 7th onwards, which was tolerated without any issues. At the time of admission, child was aseptic as his CRP was negative, his cultures, blood and urine cultures were sterile. But unfortunately, on day 10th of admission, we found there were new fever spike along with a rise in CRP, and there was a fall in platelet count, although the absolute value of platelet was normal. And there was a documentation of hypertensive episode. So in view of hospital-acquired infection or nosocomial infection. Repeat blood, urine and ET culture was sent. Antibiotics were escalated from injection piperacillin tazobactam to injection meropenem and teicoplanin. And as the child was there for prolonged duration of PICU stay with the fall in platelet count, so possibility of fungal sepsis was also kept. So antifungal injection fluconazole was also added. Within next 48 hours, we got the culture reports. Blood and ET culture was sterile, but unfortunately, there was a positive culture in urine. Candida tropicalis was present, and this organism was resistant to injection fluconazole. So, for catheter-associated urinary tract infection, we changed the urinary catheter. Antifungal was changed to injection micafungin, and within 48 hours of changing antifungal, there was a significant clinical recovery. Child became afebrile. Septic markers also in decreasing trend. So we de-escalated the IV antibiotic to injection ceftriaxone. As you have mentioned earlier, the child was presented
Can I make a comment here? Like, I would consider candida in the urine as a very non-specific, usually a contaminant. Of course, I'll take inputs from the pediatricians, but we don't give too much credence to candida growing in the urine.
Sir, but the clinical picture was indicating that it can be a fungal sepsis. Child was presented in severe critical condition with immunocompromised state, so fungal possibility can also be there, and the culture was also showing candida sepsis. So we have to address
blood culture, lot of weight. Urine, fungus going in the urine, very little weightage to that.
In pediatric ICU data is there, sir, around 5% of cases fungal sepsis, catheter associated urinary tract infection possibility is there.
Basically in the long duration stay of pediatric ICU, particularly in children, around 3 to 5% cases are comprised of fungal sepsis, and out of those 40% are cases of urinary catheter induced infection. Plus the Candida tropicalis is the ICU fungus as compared to Candida albicans. Thirdly, the child was suffering with fever, thrombocytopenia and hypotensive episode. So all these three comprised of septicemia, and the probable cause was found out as Candida tropicalis.
And child responded to this antifungal agent, so we continued. So as we have mentioned earlier, that at the time of admission, child was in severe pulmonary edema. Focus finding and X-ray was also suggestive of positive fluid balance, so we kept the child on higher ventilatory settings. Gradually the ventilation was weaned, and on the 10th of admission, first attempt of continuous positive airway pressure spontaneous breathing trial was given, but he failed. So we continued for mechanical ventilation next 48 hours. Again on day 12th of admission, second attempt of CPAP trial was given. This time child tolerated well, so we extubated and he was taken on heated humidified high flow nasal prong oxygen support. Unfortunately, there was a gradual worsening in respiratory distress and child got re-intubated on day 14th of admission. Possible reason of extubation failure in our case could be young age, prolonged mechanical ventilation of more than 10 days, longer duration of sedative and paralytic agents, and depressed respiratory muscle strength. So post intubation, we continued for mechanical ventilation for next 3 days, and on day 17th, again second time child got extubated, taken on HFNC support, but still the respiratory distress was persisting. So we did CT chest after 24 hours, which was suggestive of bilateral posterior collapse. So for this thing, we started nebulization along with chest physiotherapy, but there was further worsening in distress, and within next 12 hours of CT chest, there was an X-ray was done which was suggestive of complete left lung collapse. Possible reason of left lung collapse in our case could be, first one is the ICU acquired respiratory muscle weakness, and second possibility is thick mucus plug impactation. For that we plan to do flexible bedside bronchoscopy, which was done under all aseptic precautions. Mild sedation was used, and the bronchoscopy finding was suggestive of thick mucus plug along with the thick secretion were present over the carina and inside the left main bronchus. Bronchoalveolar lavage with 3% saline and anesthetized cystine was done. Thick mucus plugs were removed. With the help of physiotherapy department, intensive chest physiotherapy was done. Within the next 2 to 4 hours, we found there was significant clinical recovery, respiratory distress improved, initial saturation which was fluctuating 92% improved to 97-98%, and repeat X-ray which was done after 4 hours post-procedure was suggestive of improvement in left lung collapse. Finally, between second and third week of admission, we found that there was a dependency on HFNC support. There was a life-threatening event of left lung collapse. On examination, we found that there was all 4 limb weakness was present and documentation of significant weight loss. At the time of admission, weight was 15 kg, which reduces to 11.5 kg. With the background history of long duration of mechanical ventilation, sepsis and neuropathic agents used, possibility of ICU-acquired weakness was kept. The treatment of ICU-acquired weakness is to treat the underlying cause along with the nutritional rehabilitation, TPN and physiotherapy was continued for next 7 to 10 days and child responded with this treatment very well. And finally, the patient was discharged after 35 days of admission. On follow-up, we got whole exome sequencing report. To discuss about the genetic aspect, in our case, I would like to invite Dr. Rekha Gupta ma'am.
Good morning everyone. So by today's case, at the end we had 2 differentials. One is atypical hemolytic uremic syndrome without infection, and second is thrombotic thrombocytopenic purpura, and that may be also genetically acquired. So here to reach a conclusive diagnosis, we need a genetic testing. So as these are gene mediated disorders, so we need to test the gene of baby. So these are all single gene disorder. However, I put here the point on renal disorder, but basically these are vasculopathies both, and genes of some vasculopathy is involved in these cases. So we need to do test for those genes. So in atypical hemolytic uremic syndrome, genes are involved are alternate complement pathway genes. These are 10-11 genes. If mutation in one of these genes is there, then child may present with atypical hemolytic uremic syndrome. And second, our differential was thrombotic thrombocytopenic purpura. So if gene ADAMTS13 is mutated in autosomal recessive manner, then child may present with severe TTP in childhood period. So to reach the diagnosis, we offer the gene testing, and as I have told that to reach the mutation into a particular gene, most of the genes are dysfunctional due to sequence variation. It means in our body, proteins are working, and proteins are made of amino acids, and amino acids are formed by codes, like 3 nitrogen base pair code is there, and that code for 1 amino acid, and these amino acids connected and form the protein. So if code is abnormal, then that gene got dysfunctional, and abnormal function of that gene lead to the abnormal disease or disorder. So here in most of the cases, these sequence variants are there in single gene disorder, and to pick these sequence variants, we advise the next generation sequencing, and this next generation sequencing we call it the whole exome sequencing. So in whole exome sequencing, we sequence all of the exomes which are functioning in our body, and if any mutation is identified, then we correlate that mutation with our phenotype of the patient, and then we reach a conclusion. So here, when whole exome sequencing was advised, there was no pathogenic or likely pathogenic variant was identified. So sequence variants were not there in the whole exome sequencing, but we found one note in the report that they found one homozygous duplication in the CFHR3 gene. This CFHR3 gene is important for alternate complement pathway, but however this duplication is generally not reported. But this whole exome sequencing is not for reporting this duplication, because whole exome sequencing is basically for sequence variants. When a gene is defective due to deletion or duplication of multiple bases in a region, then we call it deletion duplication, and we read this deletion duplication by a technique we say it MLPA, multiplex ligation dependent probe amplification. So we need to offer MLPA to the patient to pick the deletion and duplication into the particular gene. So in this case, whole exome sequencing was normal. So we offer the MLPA to confirm further diagnosis, whether to confirm the CFHR3 mutation, duplication into the gene, or any other deletion duplication into the gene. And if we found that, then we will reach a diagnosis. Otherwise, still we are in dilemma that what is the diagnosis. If we say that it is atypical hemolytic uremic syndrome, then still we found the diagnosis is only 60% of cases, 40% of cases remain undiagnosed. So still we need to wait out further genetic reports to reach a particular diagnosis. Now I call Dr. Yashu to summarize the case.
Good morning everyone. So before we conclude the case, I would take next 2-3 minutes to summarize and share few key highlights that why did we choose this case and finally what is the diagnosis. But before I move ahead, I would like to answer the question of Malhotra sir that if the gene comes out to be positive, what are the outcomes in terms of patient life. So there are high chances of relapses, as Dr. Rekha said. Patient fastly progresses to end-stage renal disease, not in the first episode, but maybe in the subsequent relapses. But post-transplant outcomes are very good because it is genetic form of disease. If it would have been anti-factor H antibody-mediated HUS, then post-transplant outcomes are very grave and the recurrence chance are more than 90%. So the key points which triggered us to use this case was, first was the dysentery. So we thought that dysentery being
so like this is a nephrology naive audience. You are talking about a renal transplant or a hematopoietic stem cell transplant?
Sir, I am telling a renal transplant.
And then the milieu remains the same. Then you can have the same process happen in the transplanted kidney.
Yes, sir. If it is antibody mediated. So first point was the dysentery, which was a key feature but appeared to be more of a red herring symptom, because being a globally most common cause of HUS, it is usually self-remitting. We don't require any plasma exchange. And in India, more than 50% are anti-factor H antibody positive, but both of them came out to be negative. Next issue which confused us was cystocytes versus AKI. So anything more than 2% is considered significant. Our patient had 18% cystocytes, and it is usually a dictum in hemolytic uremic syndrome that more is the severity of cystocytosis, more is severe is the AKI. But our patient has a mild AKI. So because we did dialysis for a short duration, more for a fluid overload and uremic encephalopathy and not for creatinine. So it was a big mismatch. Third issue was disproportionately high blood pressure to the extent that it caused hypertensive emergency, that is the posterior reversible encephalopathy syndrome. When this happens, we expect that in patient of HUS, there is endothelial damage due to microthrombi causing vascular thickening, and this leads to a long-term comorbidity of high blood pressure requiring polytherapies in due course. But fortunately, our patient recovered and currently is off antihypertensives. Another issue was whether it is HUS or TTP. So till we got the genetic reports, at least we ruled out that this is not TTP, but whether it is a genetically mediated HUS or not, we are awaiting an MLP report, and then we would confirm that. So there was a mixed picture all throughout the treatment. And lastly, genetic mutation. So as Dr. Rekha said, that CFHR3 deletions are commonly known to cause atypical HUS, but our patient had duplication. So we need to have a functional assessment of this genetic mutation, that whether there is a genotypic phenotypic correlation between them or not. So it is a very rare case that we need to report, that in spite of if MLP is positive or negative, it is worth reporting because the patient presented in a different manner. And finally, with all these comorbidities, what we landed up was difficult extubation and ICU acquired weakness. But through this turmoil phase of 35 days, finally what we achieved was an excellent outcome, and this is the patient who came 15 days back on follow-up with no comorbidities and absolutely normal neurological outcome. So at this outset, I would like to thank all the departments of medical genetics, AIIMS New Delhi, Department of Pathology, IHBT and radiodiagnosis, physiotherapy, without whose support we would not have achieved this outcome. Thank you.